Hello, my name is Anat Loewenstein, and I'm the chair of the Department of Ophthalmology at the Tel Aviv Medical Center in Tel Aviv, Israel, and the General Secretary of the Euretina Board. I will speak with you today about my presentation during the Euretina on artificial intelligence in neovascular macular degeneration. And I would like first to tell you, why do we need at all AI for the management of neovascular macular degeneration patients? So the main reason is that during our management of our patients with neovascular AMD, we use a lot of OCT images. OCT images on which we are looking on subretinal and intraretinal fluid, pigment epithelial detachment, and we do record some qualitative descriptions. However, by using AI, we can actually quantify all of these parameters and try to really understand their influence on the management and outcome of our patients. We know that the drawbacks physicians have for subretinal, if we will use quantitative data that is looked at by AI methods, we can get many more details that can predict the response of a specific patient to a specific treatment. Also, theoretically, the technology can compare the values of the patients to a normative database and try to understand in what way and how it is different and how it can improve. So this has been tried by many groups, and because we know that OCT is such an important and crucial technology when we manage patients, we can understand how important it can be for the patients. Moreover, AI using OCT parameters in neovascular macular degeneration can really help clinical trials, because you can understand very well how does a specific drug as compared to a different drug reacts on various OCT parameters. For example, in some studies, let's look at the study like the fluid study. For example, in some studies, let's look at an example like the fluid study. The OCT outcome measure was the mean change in central subfield thickness. This was also the outcome in Hawk and Harrier as not as a primary outcome, but as an OCT outcome. So all of these measures, if you are not using AI does have a lot of limitations. If we will do it clinically, and even if we do it at a reading center level, if in a context of artificial intelligence, we can retrieve a lot of data with much less work. Also, it provides some kind of an objective approach of the software to automatically generate multiple quantitative metrics related to fluid, intraretinal, subretinal, sub-RP, any fluid, and so forth. You could also use not only the morphological parameters of the OCT, but you could combine it with the functional measurements, such as visual acuity, and combine and see what is the correlation between the two, and therefore understand sometimes why there is a disconnect, and try to understand by AI methods and by machine learning what influences the OCT outcome in addition to the visual acuity. Moreover, there are so many advances in machine learning and deep learning today that there are multiple softwares that can actually process routinely acquired spectral domain OCT data and determine the location and volumetric information of macular fluid within different tissue compartments in a very easy manner that can help us significantly. Maybe if we will look at parameters such as volume that AI can do easily using OCT parameters, we will understand better the influence of the fluid on the visual acuity. And as many groups worked at it, for example, the group of Ursula Schmidt Air Force that looked at data from the Harbor trial. And we tried to look at this data in addition with the data from centers, such as the center in the United Kingdom, and the center in Israel, and on the AREDS 10-year data. And we could find a lot of importance to the analysis by AI. Everyone had a lot of fluid at baseline from all data sets. In first treated eyes, the fluid volumes were larger compared to second treated eyes. And when you compare between clinical trial data and the real world, most of the fluid decreased after the first injections. This is consistent with previous reports. However, during the follow-ups, fluid volumes remained on a higher level in the real world as compared to clinical trials, demonstrating a need to use the precise fluid measurements for a long-term prevention of recurrence. All of this requires a very complicated precision. To gain precision, requires complicated algorithms that need to be validated in external test sets. One deep learning based algorithm is the Vienna Fluid Monitor, which trained and validated fluid segmentation in AMD, diabetic macular edema, and retinal vein occlusion. And this provides us with very important data. The NOAA, a technology in which I'm involved, is a machine learning algorithm that distinguishes normal morphological features from elevated or distorted contours to quantify macular fluid on OCT volumes. It allows to quantify intra and subretinal fluid on spectralis and on serous spectral domain OCT, and also potentially on the home OCT. The fluid output is displayed in nanoliter, very small amounts of fluid, and there are many other algorithms that did the same. There is also the Google DeepMind algorithm, which aims to perform automated referral recommendation for a range of macular pathologies, automatically segmenting the spectral domain OCT data into multiple volumes. And this also has potentially a lot of role in the future. There are barriers. It's not so simple. Sometimes it may be difficult to adapt these novel ways we look at our patients. Sometimes there are issues of reimbursement and there are regulatory issues. However, I do think that it has a lot of potential in the future, especially because we know that most of the data comes from OCT. And there are so many AMD patients that need so many treatments. Definitely, we need assistance in the analysis of the results of the multiple OCT scans that we are doing in order to better manage our patients.